So hi, I'm Annika. I'm one of the neurosurgery registrars or training registrars here at the Royal Adelaide Hospital. This is my second last year of training.
So can you tell us what first got you interested in medicine?
Medicine for me, I am from a family of engineers, but my mum was adamant that she was due to be a dentist, but from where they came from, there's not a lot of money for them growing up, and I think a lot of that inspiration came from her and just persistence and advice, I guess. And medicine for me, there was also a very key moment in time. I had my brother's best friend get very unwell, and the care that he got when he was here as an exchange student was particularly pivotal, because he ended up getting a transplant on compassionate grounds, and I think if he were anywhere else that wouldn't have happened. I think seeing that as a year 11 student for me, or year 10 I think I was when I realized if you could change someone's life in that way, and I think those are little inspiring things along the way.
And have you always lived in Adelaide?
No, I was born and brought up in Dubai, came to Perth. We migrated when I was about 13, so I've done most of my schooling here, university in Queensland, and then internship back home, so I've been around a few of the states, and Adelaide's been home since 2013 now.
So did you always know that you wanted to be a neurosurgeon?
No, I think for me, Adelaide Uni actually provides their students with a very unique experience of rotating through the hospitals and getting to spend some time on neurosurgery, but I didn't have that through university. I probably was more interested in just general surgery because that was my exposure and what I saw, and as an intern, for me, I was completely bent on the fact that I was going to do that, and that's what I came out here thinking I was going to do, until you meet someone who changes your path. And for me, it was one of the registrars at the time when I was a resident, a neurosurgeon, Alistair Jukes, and after meeting him, working with him and the team at the time, and also the consultants on rotation, I think that's what sort of changed my path. And I think in the first year, it's fascinating, and it's not always, there's highs and lows in every job, but neurosurgery does have some lows that can be quite terrible. But I think doing it and seeing the benefit that you make, for me, that's the difference. And as a resident, I think it was a turning point, and then I knew.
And can you tell us a little bit about your training journey, so from university through to being a neurosurgical trainee?
So I did med school in Queensland, so that was 4.5 years at Bond, and then I came out and did an internship in Perth. I knew pretty well after medical school that I was going to do surgery, which then, everything from there was to try and build up your CV, do the relevant courses, and so I spent sort of internship in that first residency year doing that, and it's around then that you choose a pathway, and then you start, or for me, I started narrowing down then after getting the unaccredited job a year after that, so it was probably 3 years out. And once you're doing that non-training registrar job, it's really building up your CV for points to get on. And so it's time on the job, time on the tools, but at the same time, trying to write a paper, trying to do a presentation. So to get those points to be competitive enough, it takes most of us about 3 to 4 years. For me, it took me 3 years, and to the point where I felt like I was doing too much clinical, not necessarily focusing on the academic aspects that are needed also to get on. And so that's at the stage that my mentors within the job suggested I step away and do a master's and have some time to study and also progress another area or an important part. And so then I took a research year, which was 2017, and that's when I started the master's, and also had NRF support me at that time. And then I actually got into training for the following year. So 2018 is when I started. I spent my first year in New Zealand, and then I spent the remaining years here with a gap year to go back to the research.
So I have a two-part question.
Yeah.
So for those that don't know, what is a non-training registrar position versus a training registrar?
Yeah. So for us, training positions nationwide, so Australia and New Zealand, they take about 6 to 8 trainees a year. And so these numbers may be wrong, but off the top of my head, I think there was about 50 to 60 that applied in my year across Australia and New Zealand. We go through a CV selection, references, interview, and at the end of that, 6 to 8 people are selected, so I think 24 people interview. And so the jobs, though, still need to be filled. You can't have one trainee running the place. So generally, every hospital is staffed with 1 or 2 training registrars that are ticking time, essentially. You're going through the curriculum over the years, and at the end you are then qualified per the college requirements once you sit the exit exam. So that's the training process. Whereas as a non-trainee, your time that you do is, it's not counted in terms of that, and you don't get the qualification and at the end until you get on and go through that process. So unaccredited or non-trainees, there's about 2 to 3 per hospital, sometimes more, depending on the eastern states and so on. They have more than they do here. And it's an opportunity to just do the job, be hands-on, but also build up your CV and the points that will get you onto training at some stage. And it's also an opportunity to, it isn't for everyone, and if there isn't a way to try it, how are you going to know? And often unaccredited or non-training years are used to try and live the job and see if it is truly for you. Because once you're in the training program, it's a big commitment. You're committed to the role now. Whereas as a non-trainee, you do have options to change.
And once you become a trainee, it's probably quite variable, but is there sort of a standard amount of time that takes to complete the trainee years?
Yeah. Minimum of 5 years, and it's in recent times it's changed and it's divided into sort of basic, intermediate and advanced training, and 1 to 2 years in each sort of segment. And you have to fulfill a series of operative cases, assessments every 3 months, and certain requirements along the way to then qualify and then keep getting upgraded till you're cleared and ready to sort of sit your exit exams.
And you also mentioned that you worked in New Zealand, so how did you find that experience?
Yeah, it was really good actually. Funny enough, when I opened the letter and told my bosses, I think one of them was like, "Oh, enjoy Waikiki," and I was like, "No, I'm not going on holiday. I'm going to Waikato, New Zealand." And look, it was a different experience. It was, I think, people. Pathology was exciting there in a way, because I was it was North Island, but it was a retrieval service, so things were coming in much later than when they would present here, so tumours were bigger, and it was just a different sort of neurosurgery that I saw then. And they're a little bit, in terms of the luxury that we have here, or CT scans, introp CT, all of that, they're a little bit behind, so it's just working with what you have as well, and not, the luxuries of here, it's not always available there. So it was a nice different experience to start with, and that was my first year of training, and then came back here. We recently have started to have choice in terms of where we do most of our training. We now select a home state, so a lot of people that get on from South Australia end up now staying in South Australia, whereas before we used to have to move every single year, or it was just July you got an email saying, yep, this is your next spot. So things are evolving, because I think moving around every year is disruptive, and they're taking that into account. But it was nice to see something different after spending 4 years here before getting on. So yeah.
And so you mentioned you did a master's and you're in the middle of your PhD at the moment. So what's your sort of area of research and specialty?
So my PhD is essentially based on anterior skull-based surgery. And so that's looking at operating through the nose because, current day and age, everything is about minimally invasive. How do you limit the trauma that you create? Big incisions, and if you can do it through a small hole or no scars at all, that's the next step. And with all of that comes being able to do the best job in those confines. And so with the PhD, the focus has been anterior skull base, operating through the nose particularly, and that's not only to try and best manage, it's also, I guess, a big interest of mine has always been teaching. So simulation training is another thing I've incorporated to the PhD, and then at the same time it's also how to manage bleeding, which is one of the biggest problems we encounter in neurosurgery, in that manner.
And is there a lot of simulation training at the moment in the training program?
It's I guess general surgery was where it all started, laparoscopic or keyhole surgery, and that's been the biggest driver of simulation training. ENT and neurosurgery, because anterior skull base is essentially a joint area from that aspect, and yes, simulation training is expanding. But it's been around for a while. It's just what's the best way to do it is what the research focuses on. Is it just a model you build on a bench, or is virtual reality the next step? And so I think in terms of simulation, it's very important that it is around, but is it the best way to teach the skills that you're trying to teach is what's always up for discussion. And I guess you always want something that's as realistic as it could be, and how best to achieve that has been the focus of things here.
That's great. What's the most hours you've ever worked in 1 week?
127 in a fortnight. So let's put that into 60 plus. Yeah.
What's the longest you've ever gone without sleep?
3 hours of sleep and a 24-hour shift, or it can be less than that. Yeah.
What was your first surgery on a real patient?
Something we call a subdural hematoma, a blood clot in the head. Yeah.
What is the longest surgery you've ever performed?
Close to 12 hours. Yeah.
What's the most surgeries you've performed in 1 day?
4. Yeah.
What's your most common surgery that you performed?
Something we call subdural hematomas. Yeah, it's very common. Yeah.
What's the most complex surgery that you've performed?
Clipping an aneurysm for me. Yeah.
And so you work and train here at the RA, where we are currently. Are you based anywhere else as well?
Yes, so every year since I've been back, I've gone between the two hospitals. So in Adelaide, the major training centres for us are Flinders and Royal Adelaide. And Royal Adelaide sends us, offers a secondment for about 6 months if we need paediatric time. So it's also attached to the women's and children's. So I've rotated between the three, and next year I will be at Flinders as the next job.
And have you had any sort of standout memories or moments along your training that you'd like to share?
Many. I think as a trainee, I mentioned earlier that we've got these sort of goals and targets we need to achieve as we go along, and for us, I guess, operatively, the minute you have done a case that, from start to finish, that is technically advancing your skill, that always gives you a degree of, job satisfaction or personal satisfaction. Standout moments, there are plenty of patients that come to mind, along the way, and it's really not one. I can't pinpoint one specific thing, but you see them come in and you deal with them, their family, the difference that you make, if it's even if it's something as simple as, you know, taking their pain away because you took a disc fragment away. It might have been a 45-minute operation or an hour operation, but, you know, they were in pain for months on end, and they turn around, they're like, great, you know, you've helped and made me better. And I think even the simple things still leave an impact along the way. But yeah, not one particular moment.
And one of the biggest challenges must also be some of the patients that you've had in those harder times. One question I have is there much training around how to deal with those really challenging situations, or is there a particular approach that you take?
No, I think for me, I was just trying to think back. So I finished med school quite young, so I was 21 when I finished. The first patient that I still remember that I, you know, sort of gave bad news to or could not help as much as I wanted to, I was 23. You know, telling someone who was 70 plus that we couldn't do anything for them. And I think I still remember going home and going, what am I doing? And you know, how am I doing this? And it hurts you, and it hurts you along the way, but you just put it, you know, in a box behind, and you learn from each one that you do. You watch your, you know, your consultants or your fellow colleagues interact with people as well, and you, it's empathy along the way. I think if you retain that, you have to feel it, but you have to also put it aside to be able to keep moving on and keep having a strong, long career within it as well, and being able to do the right thing for your patients. So you don't get any formal training on it. You watch, you learn, and I think for me, it's how would I want to be treated is what I think about when I speak to patients or need to communicate something sensitive. It's just how would I want to be treated, and I think that's helped along the way, I think.
And so I'm sure every day is different, but can you give us an example of what sort of a day might look like for you?
Okay. Yesterday, for example, we've got a team of 4 registrars. We had 2 theatres running, the elective theatre in the morning. Usually we have a clinic every afternoon as well. So for me as the senior, it's a matter of making sure that we're staffed and running in an appropriate way, and places that we need to be are covered. The ward is important, holding the on-call phone is important. So my day yesterday was the elective theatre, and so it's meeting patients before surgery, checking their symptoms, making sure the theatre runs well, keeps moving on to the next patient, updating the families, and at the end of the day, we do a couple of handovers. So it's usually a handover in the morning, handover in the evening, and I wasn't on call, but sometimes there's a 1 in 4 on call at the back end of that. But yeah, that's a typical day.
So what would you give to a student who is considering pursuing medicine, and particularly neurosurgery?
My biggest advice actually at the moment is embrace everything. So as a medical student, I generally say to them, yes, neurosurgery, on paper it's enticing, it's unique, it's such a it's the young specialty that's growing. There's so many areas of improvement and evolution that are happening, whereas I do say, general surgery has been around for so long that innovation exists, but not at the rate that it's currently existing in neurosurgery in our time and day. But the thing for me is that, just like my research, my supervisors are ENT surgeons. So don't shut off to anything else. Embrace every other surgical specialty, because within neurosurgery, you do a bit of ears, nose, and throat. You do a bit of plastics. You do a bit of vascular. You do a bit of orthopedics when we work with spines. So my advice to them is embrace everything. Work hard at everything. And if you do come back and say neurosurgery is where it's at, all of those little bits will help you at the end. That advice actually was given to me by one of the neurosurgeons in Adelaide also.
So you've mentioned your research that you're doing, and so what is your relationship with the Neurosurgical Research Foundation?
So I applied to the Neurosurgical Research Foundation to help with funding when I started my master's in 2017, and actually around that time my sort of awareness of NRF was built by the sort of Brain Tumor Foundation relationship as well, and I'd met Jinta a few times on some of the open days when I was a registrar at Flinders, and I applied and achieved funding for the sort of simulation training model, and then following that, after I got into training, I took some time away, and then I came back, and eventually with the experience I was able to sort of turn the project into a PhD, which I took a year off training to do last year, and again approached the NRF, who I'm particularly grateful for, because it was an opportunity to sit with Dr. McCulloch and Jinta and talk about what I had as goals with the PhD, and as I said earlier, a big part for me is the teaching side, and to be able to with the funding that I got last year, not only run a model on the hemorrhage control or bleeding control side of things, which is an important part of the surgical aspect to this. I was actually able to run that pilot course successfully, and so after 2 years and generous funding from the NRF, I have finished all my projects, and it's now just in the writing phase, and I'm excited. Yeah,
that's great. And so August is Neurosurgery Awareness Month, so do you have any aspects of neurosurgery that you wish there was more awareness around?
I think for me, it's probably a selfish interest, but I am interested in vascular. We talk about the impacts of brain tumor, and we are aware of it, but the impact of vascular events is also a very important thing. I know the NRF has focused a lot on brain injury, and then the tumor side of neurosurgery, but vascular is something that I guess we don't talk about as openly as something that does impact. Yes, I've had a vascular event happen, and it's just you move on and you have rehab, but it still impacts quite significantly, and it's not spoken about. So that's probably my other aspect of more awareness, I think.
So when you say vascular, you mean stroke, and what sort of other conditions?
Yeah, I guess with brain tumor, the research in that sphere is important because there's no cure for that pathology, and we need to be working towards finding some way to end that. But strokes, it's such a common pathology. Not just strokes, it's aneurysms, bleeds, other vascular malformations. There's a general incidence in the population, 1% to 2%. Anyone could have an aneurysm, walking around. And the split second that it then ends up in hospital, and the impact that it has, I think a lot of it is just, I had my stroke 10 years ago, carry on. But it's still a burden on that patient, on the family, and the society. So it's still something that I think, we should be aware of, and there should be work into stroke and vascular side of things neurologically. And I think that's an important area. I had the pleasure of working not quite alongside, but in different theatres, and so Annabelle Sorby Adams, Adam Wells, they've all been supported by the NRF, and their work has been on a stroke model of injury and brain trauma. It was exciting to sort of be in different theatres and also communicating about all of those things when I was operating as part of the research in 2017, but it's very important. And so NRF has supported it, but the awareness side of things is not as much as the brain tumor side of things, and it's an important thing.
So outside of neurosurgery, what do you enjoy doing in your spare time? What are you passionate about?
Look, I was on a basketball scholarship through high school, and I still enjoy playing. So whenever I can get out of the hospital and I'm not studying, that's probably where I am at. But at the same time, I've got a 2-year-old golden retriever, so he keeps me very busy in terms of trying to walk him and run him and take care of him. So that's where I am, other side.
I think I know the answer for this, but they don't have a basketball court in the hospital.
No. But if we could change the formation, I'd probably add one here.
Just a ring somewhere.
Just a ring. Yeah.
Good for patients as well.
Yeah.
So the last question is, do you have a quirky or interesting fact about the brain or neurosurgery?
Not at all. Not at all at the moment. Not at all.